What about postmenopausal patient but not bleeding? Should we offer additional investigations to asymptomatic women with an increased stripe? This is very controversial. I think the best paper out there is from UCSF. It's a meta-analysis, and basically they said that over 11 millimeters is when you pull the trigger to offer endometrial biopsy, whereas under 11 millimeters, the risk-benefit ratio isn't appropriate there. You can argue this, it was a meta-analysis, but it's probably the best data that we have. All the gynoncs that I've talked to think this is reasonable. Remember, we are not offering a screening exam here. This is just when grandma comes in, she's not bleeding, and we're looking for an adnexal mass or appendicitis or whatever, and we happen to see something over 11 millimeters. The last scenario is tamoxifen. As we all know, tamoxifen is great at treating breast cancer. It halves the risk of breast cancer recurrence, but it does increase the risk of endometrial issues. This problem may be going away as we're getting some more selective estrogen receptor modulators, but they're still not in wide use right now. And so just as in patients on hormone therapy, the endometrium in patients on tamoxifen is going to be abnormal. It stays abnormal for a long time after you quit taking it. It decreases about 1 ml per year right there. So if you've been on tamoxifen for 5 years, it may take a while for it to come back down to normal. Bottom line, there's a little bit of controversy out there, but all the gynoncs I talk to say we really shouldn't be imaging women on tamoxifen because it's going to look abnormal, we're going to get worried, so they more or less treat symptoms. If the patient's bleeding, then they go ahead and deal with it. So you can see in this case here, we have a 34 millimeter thick endometrium. A couple months later, it's 5 centimeters thick, looks very abnormal, and these turned out to be benign polyps. So to sum up all of this complex stuff here, postmenopausal with bleeding, this is the most important category, over 5 millimeters. It doesn't mean you have cancer, but we need to evaluate. If you're postmenopausal bleeding on hormones, if you're postmenopausal bleeding on tamoxifen, we still use 5 millimeters. If you're postmenopausal and you're not bleeding, we use 11 millimeters. And if you're premenopausal, we use 15 millimeters. This is very complex. Ruth did a superb job writing up the consensus statement, so take a look at that if you have other questions. So now let's move on to abnormalities seen on transvaginal ultrasound. As we said before at the beginning of the lecture, most women, fortunately, who are bleeding, who are postmenopausal, don't have cancer. 2/3 of the time it's atrophy. So here's a great appearance of an atrophic endometrium that just needs medical management, doesn't need anything else. We can see polyps transvaginally. Here's a classic appearance of a polyp. This is not an SIS, this is a regular vaginal scan. This is kind of an interesting one because, again, this is not an SIS, but you can see the polyp kind of peristalsing back and forth with myometrial contractions there. It has the classic appearance of a polyp with a single blood vessel going into the stalk right there, and this was a benign polyp. We've all seen 1 million fibroids. The key thing here is submucosal location, since we're worried about abnormal bleeding. And then the thing that we worry about is endometrial cancer. And even though this appearance here is great for a polyp, it's homogeneous, it's hyperechoic, 99% of this was benign polyp at surgery, but 1% in the top left corner, there was a focus of grade 1 adenocarcinoma there. So focal masses are surgical masses, they generally come out. Let's talk about some of the other diagnostic modalities out there. And again, it's not that something is good and something is bad, each has strengths and weaknesses. Now, the classic imaging modality was the hysterosalpingogram, and we did that in the old days before we had something better, but it has completely fallen out of favor for evaluation of the endometrium. It has way too many false positives, way too many false negatives. Here are 2 different REI patients who had focal masses. One of these turned out to be a polyp, one turned out to be a cancer. So the only thing we're doing these for now is tubal patency. Dilation and curettage, or as my mother-in-law calls it, dust and clean. This is the classic diagnostic test. Because of the morbidity, discomfort, cost involved, it is no longer a diagnostic test, it's just a therapeutic option. The key thing about DNC is remember that you only sample 10 to 20% of the endometrial cavity. So it's good for endometrial cancers because cancers tend to be large and they tend to shed cells, but for focal lesions, it's not nearly as good. What's replaced DNC from a diagnostic standpoint is the endometrial biopsy right there, or EMB. And there's a bazillion different catheters out there, but basically you put them up and you sample some of the cells. This only samples 15% of the endometrial surface. So again, it's very good. It's not perfect, and there are some papers that say that endometrial biopsy is far from perfect, but in general, most people say that endometrial biopsy is good for cancer, but it's horrendous for polyps. In the Sloan Kettering study, it picked up only 4% of polyps. And as we try to distinguish between using endometrial biopsy versus SIS, endometrial biopsy hurts a lot more than SIS. Hysteroscopy is kind of the gold standard. Remember, there are two different types. There's in the office with the little midazolam fentanyl, and there's in the operating room. We fill the cavity with fluid, put in our scope right there. Obviously, the operating room version, you can use bigger scopes and see a lot more and do more, but it's a lot more costly and has more morbidity there. And there's a lot of papers that says that SIS is as good or better than hysteroscopy in finding lesions. Obviously, we can't do something about the lesions once we find them, though, with SIS. Let's now talk about saline infusion sonohysterography, which I think is really underutilized in evaluation of the endometrium. And we'll divide this lecture within a lecture to an overview, technique, and then a bunch of examples. And even if you do not do SIS, although I hope you consider it, I think looking at all these examples will make you a much better sonographer. So there's a whole bunch of different synonyms out there for SIS there, and it's a mixture of the etymology of Greek and Latin, but it literally means writing on the uterus with sound there. Primacy is always tough to distinguish, but the first paper I found was by Nannini in 1981. It's still an active research area. You know, over a 5 or 6 year period, I found about 70 citations, and that was just searching for one word. If you search for all the other synonyms, you'd find a lot more. We average about 2 a week. You know, it's not high volume, but it's solid. It's not a difficult study to perform. One of the key things to remember about SIS or any screening test is that some expert in their ivory tower may have a wonderful test, but if you and I can't use it, and we have 300 million people in America, it's not going to be a good test there. So one of the beautiful things about SIS is that the average person it works great for. And there was one trial where they compared nurses to second-year resis, to fourth-year resis, to fellows, and found equal accuracy. Another person basically said the same thing there. Now remember, when we talk about SIS, we always perform a full transvaginal ultrasound as part and parcel of it. We look at the uterus, we measure the fibroids that are sticking off to the side, but we're not going to talk about that here. We're going to focus about the SIS. And in this era of rising costs, you start to wonder, is this overkill? We like technology in America, but does it really change outcomes? And so there's a very small minority of the papers that say that if you're really good, you don't need SIS. And that may be true if you're really, really good. So here's an example of a small polyp right here, and I think we would all agree that it's there, and you see it much better on the SIS. But conversely, take a look at this case. Here's the midline, and then to show you that I'm not cheating, I'm sweeping from side to side, showing you the entire endometrium, and even retrospectively, this looks normal to me. We do the SIS, and there's an obvious bump, plain as day. So the overwhelming bulk of the literature says that transvaginal ultrasound is not good enough there. And just picking one paper out of there, a quarter to a third of the women with a normal transvag had an abnormal SIS. So what are the indications for SIS? Pretty much anything to do with the endometrium, anything that you can think of. One of the classic indications is discordance. Here's a 48-year-old who had irregular bleeding. Her stripe was 17 millimeters there. Her path showed normal endometrium. Well, we've got discordance. We've got normal path at EMB, but we have an abnormal stripe, and she's symptomatic. She's bleeding. And as we said before, endometrial biopsy is pretty good for cancer, but it's awful for focal lesions. So we went and did this SIS, and here you can see an obvious in 3 planes right here, large 4-centimeter polyp, and that explains her bleeding.